Hello and welcome everyone. My name is Sally Pinto and I'm from the Yonkers Newark neighborhood naturally occurring retirement community. We launched back in January of 2020 and we're here to serve seniors 60 plus in Northeast Yonkers. We have lots of fun programs and activities, and we also have a lot of resources for you as well. Our programs include meditation chair yoga, body mind fitness, bingo, and any other programs that you might be interested, like arts and gardening. We have our resource specialist, Alexa Smith, who can help you with finding services and activities out there for you, as well as our nurse, Barbara Simone, who can help answer your health-related questions. We're here for you, we're here for our community, and we look forward to seeing you in our programs. Enjoy.
Hello, everybody. I'm Alexa Smith, the resource specialist with the Yonkers Newark. I'm here to help with application assistance, referrals for home delivered meals, and transportation services will be coming soon. We also offer Zoom activities and Zoom programs. And if you have any other questions or concerns, I'm here to help. Thank you so much and enjoy the program.
Welcome. I'm Barbara Simone, registered nurse. I recently retired from Westchester County's Health Department as a public health nurse. I am now here to try to assist you with any medical or preventive care issues. Enjoy this program, and I'm looking forward to working with you.
This is Elisa Hahn from the Marketing Communications Department at NewYork-Presbyterian. Good afternoon,
Thank
Elisa.
you, Sally. Good afternoon, everyone. And I'm with you, Sally. I can't believe it's been a year since you've kicked off the NORC. And congratulations to you and Kelly at the Office for the Aging for really initiating an amazing program for seniors in Southeast Yonkers. I know that you've done an amazing job this past year and offered all sorts of programming, and it's been a real benefit in the community. So thanks to you, Sally, for your leadership, and to Z for your partnership. We're very happy to have Dr. Goldwaser with us. I'd like to first, before we hear from him, share a little bit about Lawrence Hospital. We have been around, guys, since 1909, and we joined the New York Presbyterian Regional Hospital Network in 2014, became an official campus of NYP in 2018, and what that has meant for us is that we have a lot more physicians and surgeons like Dr. Goldwaser now part of our team, offering advanced services, clinical trials. There have been a tremendous amount of benefits that we've had to offer our patients. We've been able to offer our patients since we became part of New York Presbyterian. We have a Commission on Cancer designated cancer center, which opened a few years ago, state-of-the-art infusion space. We also have state-of-the-art operating rooms. That's a photo of one of our rooms that has tremendous digital capabilities. We have a private postpartum unit. We are a New York State designated stroke center, and we have a couple of centers of excellence in breast imaging and bariatric surgery. And for those who have trouble sleeping, we do have a sleep center on site that is overseen by a board certified sleep specialist. Everyone is talking about COVID. We know that's top of mind. Since the COVID pandemic has happened, we have instituted a number of safety protocols and systems in place to make sure that you are safe when you come to the hospital for care. We want to ensure the care of not only our patients, but our staff and our visitors. So that is our top priority. We also have medical group offices scattered throughout the community. Those are also safe. We've staggered appointments. We don't have people waiting in waiting rooms together and congregating. So there are lots of protocols in place to make sure you're safe and you feel comfortable when you come to see the doctor. New York Presbyterian Lawrence Hospital is very committed to serving the community in a variety of ways. We donate coats and food to local pantries and homeless shelters. We offer support groups. We have health classes and charity care. And what is charity care? If someone needs to get hospital care, if they need to see a doctor, they should go see their doctor. We have financial aid available, and we have information on our website in multiple languages. So it's it's important that you do not delay care. If you need it, you need to pursue it. Now, without further ado, I'd like to introduce you formally to our featured speaker today, Dr. Elan Goldwaser. I count him as a good friend and a great clinician. Dr. Goldwaser is a sports medicine specialist at NewYork-Presbyterian Lawrence Hospital and Columbia University Medical Center. He treats athletes of all ages, and he also focuses on rapid in-office relief of pain and injury. In doing so, he uses minimally invasive techniques like ultrasound-guided interventional procedures, including the use of stem cell and PRP treatments. Dr. Goldwaser is a 2013 graduate of Rowan University School of Osteopathic Medicine, where he learned manual therapy, also known as osteopathic manipulative medicine, as an additional tool for fast relief of acute pains and aches. He completed his residency in family medicine and osteopathic manipulative treatment, also at Rowan, and a sports medicine fellowship at Lehigh Valley Health Network in Allentown, Pennsylvania. Dr. Goldwaser currently serves as team physician for the United States Ski and Snowboard Team, Fordham University, Mercy College, Manhattan College, and as ringside physician for the New York State Athletic Commission. When he's not treating patients, Dr. Goldwaser enjoys running marathons, traveling, and playing Scrabble with his family. Please welcome Dr. Goldwaser.
All right. Well, I'll take the screen here, and thank you, Elisa, for that. Let me pull this on up. All right. So before we get started, thank you, Elisa, for that introduction. That was very kind. And thank you also to New York Presbyterian for inviting me to be part of this fantastic lecture series. And thank you, Z, as well, and the Crestwood Library, and then Sally and the NORC as well. So, you know, a lot of thanks all around here for having this great kind of event. And I'm hopeful that I can teach you all a thing or two today about arthritis and, you know, all the different options. One of the common questions I get is, do I have to get surgery, or is this something where, you know, I just have to do physical therapy, or is there something in between? It's not so black and white the way we treat arthritis these days as it used to be. There's a lot of options out there. And while I'm sure many of you have heard of an option here or there, there's plenty that we're going to go over today to kind of help, I guess, open our minds and kind of expand the possibilities of what we can do when arthritis starts to become an issue. So let's go forward here. Now, I am a consultant for Lipogems, which is the stem cell company that I'll be talking about. That plays no bearing into my bias or anything for this talk. So with that in mind, what we're going to talk about today is why arthritis is such a big deal. We're going to talk about, you know, how do you know if you have arthritis? And for the most part of the lecture, we're going to talk about what we can do to treat it. So, that looks like I clicked that. So why is arthritis important? Well, because it affects a lot of people. You know, so far that in a census kind of study, there were 27 million people documented as having arthritis of some kind. That's not a small number by any means. And even more astounding is the medical cost numbers that go along with it. $190 billion are allotted to arthritic care. And so there has to be better options than just kind of surgical, which tend to be the highest costs. 1 in 2 adults will develop knee arthritis, for example, here, and then 1 in 4 will develop hip arthritis by the age of 85. So these aren't numbers to kind of laugh at. It's important to know that, you know, arthritis is a common ailment, and there's a lot of things we can do to treat it. How do you know you have arthritis, or how do you know you're getting arthritis? Usually the joint in question will start to feel a little achy, stiff, will start to get a little dulled down. Sure, there's the classic deformities that you start to see in the fingers where they start to turn, or the knees start to buckle in, or even your toes. Everyone's aware of the classic bunion that happens. And usually a bunion is what arthritis looks like. The joint starts to turn and kind of collapse on itself. Flexibility gets compromised, and we start to feel a lot more stiff. And this happens over months. I mean, this isn't like a night and day thing where you wake up one morning and have arthritis. This is something that develops over many months to years to even decades. So, you know, arthritis doesn't have to mean pain though, and that's part of what we're going to talk about. When we look at when arthritis typically tends to hurt the most, it's usually when we're inactive. So you'll see a lot of commercials saying, oh, you know, the cure to arthritis is motion and to keep moving, and a body in motion stays in motion. It's absolutely true. Also in hand with that is that in the morning when we wake up, typically we'll feel a little more stiff than usual. And as you start to move and kind of loosen up the joints, they feel a little better. And that just speaks to the overnight kind of laying still for so long that the joints stiffen up. So what exactly is going on with someone with arthritis? This is, you know, more than I want you guys to kind of understand here, looking at this crazy here, but it's kind of where we're at with science. You know, about 15, 20 years ago, we didn't know all of this stuff. We knew, yeah, at the turn of the century that arthritis was inflammatory, sure, but we didn't know how. And through all of this research, through all of these studies, we're able, and all of the imaging that we're able to get, we're kind of able to see why arthritis is what it is. On the left side of the screen here, and if you can see my mouse, on the left side is the normal joint. On the right side here is what happens in arthritis. And there's a lot going on here in this pink area that we'll talk about. But for the general public, for the patients, for you guys that come in and say, you know what, I'm in a lot of pain here in my joint, I'm not sure why. What is arthritis exactly? Well, let's use the knee, for example. If we think of the body as a, you know, in terms of our skeleton, it's not the typical skeleton you think of when you go to biology class in high school. It's not like one of those plastic skeletons that sit on the, you know, the hook up top and it's very rigid. No, our skeletons are very sponge-like. They are very malleable, and they can they move and conform to kind of the function that we need them for. And so that's why you see people who hunch over their entire lives start to develop a little more of a curve in their back, just because the body's skeleton conforms to the function that they've been doing their whole life. It's kind of when your mom told you way back in the day, if you keep making a thing like that, you'll stick that way. Well, that's exactly what arthritis is. When the body's bones, as you know, malleable, movable components start to move around, the bones can rattle around. And if the body doesn't have muscle strength to hold those bones in place, what happens is the bones start to collapse on themselves. And when they start to collapse on themselves because the muscles can't hold strong, then the body has to pump a bunch of fluid into the joint space to push those bones apart so they don't rattle into themselves and cause pain. The cartilage that sits between the bones is like a bumper. It's like a buffer. It kind of prevents pain from happening when the bones kind of hit themselves. But over time, that cartilage can wear away and become painful. And that's when arthritis really starts to settle in. That fluid that I mentioned, well, think of it like the body's airbag. When the bones are kind of getting too close together, the body pumps all that fluid in there like an airbag to blow open and push the space open so that the bones don't hit themselves anymore, which is great because then that arthritic pain settles down. But it's also a problem because the swelling causes a lot of stiffness in those joints. And then in the morning when you try to move, that fluid in there makes it very uncomfortable, very stiff, and ultimately very painful. So there's a lot of mechanics as to why arthritis hurts, but the big one is that without muscle strength, the bones kind of collapse on themselves and then the cartilage wears away. So how do we know if we have arthritis? You know, how do we prove it? Well, you can feel that way, but when you come on into the office, we take a look at X-ray imaging because that's really the best way to diagnose this. Yes, physical exam, we can see it for sure, but with imaging like X-rays, you can definitely quantify just how severe the arthritis is. When we look at the bottom left picture, you'll see a normal knee. You can see a lot of space here between the femur and the tibia, or between the two bones. And it's very rounded and smooth, and it just looks like a normal knee. But when you look to the one next to it, you'll see that joint space in the middle is starting to collapse. And on this one side here in particular, that's the medial or the inner side of the knee. That's going to create a lot of pain kind of on the inside or inner part of the knee. And you can see there's, well, it's tough to truly tell, but there is a big bone spur here. A lot easier if we were on, you know, the computers here in the office looking at it, but there are a couple bone spurs, and that's one way to diagnose arthritic change. As the joint collapses more, and then we move to the next picture over, letter A, you'll see the cartilage space is severely limited. I mean, on the outside, on this part of the knee here, the cartilage is thinned down, but on the other part of the knee here, it's bone on bone. There is no space in between anymore. And with that, you can see there's a bright white line that's starting to grow here. And that bright white line is extra calcium. The body deposits calcium on areas of stress. So if your bones are collapsing on themselves, your body's going to put more calcium there to reinforce that bone and to make it stronger. The problem with that is that it's too late. The bones are grinding together, and those extra bone spurs that form can severely limit your motion. And when your motion's limited, that's when it starts to really hurt because you can't move the way you used to. When we look at the picture all the way to the right, you'll see the kneecap here. There's a big sharp bone spur at the top of it right here. And there's even a little calcium in the muscle area here, but that's separate. And then this little black area right here is fluid inside the knee. When there's fluid building up in the knee, again, you'll feel stiff and achy. You could even develop in the back of the knee what's called a Baker's cyst, or a big bump back there. That's also painful to touch. So there's a lot of ways to treat that kind of a thing. How do we stop arthritis from happening, though? I mean, I know we talk about treating it, but can we prevent it from happening in the first place? Well, yes. There's a lot of factors that play into arthritis. The big one is genetics. You know, if your parents had arthritis, then chances are you'll likely get it around that age. But it's not always black and white like that. A lot of times arthritis starts to develop, again, like I was saying, when we stress the body inappropriately. So, for example, the knee, if we don't keep up with the strength of the hip to hold the knee in place, the knee then collapses on itself. And if the foot is a little flat, again, that puts a lot of pressure on the inner side of the knee, and then the knee collapses on itself because the pressure isn't in the middle of the knee, it's off to the side. So I kind of coined this term here. I'm pretty much the only one who says it, but it makes sense for arthritis. We look for biomechanical stabilization, or in other words, we look to make sure that your muscles are optimized and your strength is aligning your bones appropriately so that the pressure through them doesn't awkwardly stress the bone and create more bone growth, bone spurs, arthritis. Once we have arthritis, though, what can we do? Because most of us don't realize we have this until it's too late. So there's only 2 researched and documented ways to stop arthritis in its tracks, to prevent it from getting worse. The big one is weight loss. Losing only 5% is enough to change the course of arthritis and to stop it from advancing. Why 5%? Well, in studies, a long time ago, they showed that for every step you take, and we'll use the knee as example again, it's about 3 to 4 times your body weight and force that goes through the knee. So if you think about it, 5%, that's, if I'm, for example, me, I'm 200 pounds. So if we look at 5% weight loss there, that's about 10 pounds, which means that's 40 pounds of force that goes through the knee every step I take. Jogging, it's even more. If we jogged and if we ran, you're talking 8 times your body weight and force. Now, I know a lot of us aren't running marathons and things like that, but still 40 pounds from walking is a lot to lose to it's like taking off a full backpack full of books. That can really kind of spring you up in a way and you'll feel better. Replacing the joint is obviously the other way to stop arthritis because you're just taking the whole thing out and putting in metal. But that's surgery. And so it seems like our options are a little limited in that regard. There's newer technology coming out these days that we're about to talk about that can sit in this quote unquote treatment gap between doing physical therapy and doing surgery. So what are our options? There's conservative management, which, consists of, like the word says, conservative treatments that really don't do much to the body itself, but can help kind of curb the progression of the pain and arthritis. There's interventional management, where we're using needles and ultrasound and diagnostics to really look inside the joint here and see if we can calm it down. And then there's, of course, the surgical management, which we'll touch on as well. So looking into the conservative management, or rather, did I say, anyway, surgical management before. So conservative management now, when we look at how we address this, most of us have heard of RICE, which stands for rest, ice, compression, and elevation. Why is that so important? Well, when we rest, first of all, you're not stressing that joint, so you feel better. When you're icing this down, you're squeezing fluid out of the joint by compressing it with cooling kind of properties. The cold constricts blood flow and blood vessels, and it squeezes fluid and blood out of that area. So you end up feeling better. When we look at compression, you're doing the same thing. You're squeezing fluid out of there. And when you're elevating it, you're helping the body drain blood flow back to the heart. So that helps kind of get fluid out of there as well. Compression stockings can help that too. There's a lot of different conservative managements with regards to supplements. Some studies have proven that vitamin D, fish oil, turmeric, garlic, as more herbal treatments there, those can really help in kind of building bone strength and curbing the arthritic pains and calming inflammation. There's a lot of other kinds of treatments here. A lot of people take glucosamine, but there's been no data to prove that glucosamine chondroitin really does help. So what I tell patients is, there could be a genetic predisposition to it helping, so take it. And if it helps, great. If it doesn't, well, we've tried it and we can move on to the next thing. CBD, a lot of people come in asking about that. There is zero evidence that that helps with musculoskeletal injuries and arthritic pains. However, I tell people, try it. If it helps and it's something you wanted to try and it works, then great. But if not, hey, you've tried it and you can move on to the next thing. So other conservative managements that are outside of what I'm doing here, but I'm referring the patients out, is looking at chiropractic work to realign the bones, physical therapy to build up the muscle strength, and what I do in the office is osteopathic medicine to help manipulate the muscles and kind of rebalance and realign the body's tissues so that everything's kind of sitting in good and even tone. Dry needling, acupuncture, those kinds of things can really help. And the modalities that physical therapy does too, like TENS units with the electric stim, the ultrasounds, all of that. Other conservative managements are creams that most of us might have tried or heard of, like Icy Hot, Bengay, BioFreeze. All of those are kind of numbing menthol kind of creams. Then there's Asper cream, which is more of like a lidocaine type cream, and Salon Pause, which is the patch version of Asper cream, which is more of a lidocaine type patch. There's also herbal supplements like arnica gel and capsaicin cream, which is chili pepper powder. Those kinds of things can really help. And a lot of people swear by Epsom salt soaks. There was actually a study a couple years back showing that Epsom salt soaks do actually help kind of calm the pain down. So it's a good thing to try. It's magnesium salts for the, if we're curious as to what Epsom salts truly are. There's also lidoderm patches, which are more lidocaine type patches like Salon Pause. There's Pensed too when we get into the more medicated creams. And Pensed is like a liquid Advil you'd rub over the area. It's the same thing as Voltaren gel or diclofenac, which just recently went over the counter. So it's a great thing to try, the Voltaren gel that is, if you don't have any heart conditions or blood pressure issues that would prohibit you from trying something like these Advil type medications. And above that, you'll see Celebrex, but the newer cousin of that is meloxicam, which is like a 24-hour Advil. Those are more stomach irritant sparing, so it's safe to take those, and they really do help. And of course, we all know Advil, Tylenol, Aleve, those kinds of medications. Of course, if we need something stronger, there's the idea of tramadol, which is more of a non-opiate agonist. So it kind of acts in the same manner as an opiate, but it isn't truly an opiate. I tend to stay away from those medications because the last thing I want to do is make patients a little sleepy and loopy, and that can sometimes happen. Now, there are a couple other medications here that are more advanced, which are like Cymbalta or duloxetine, which is an antidepressant, but we can use that as also a pain medication too. In a lower dose, it can help with arthritic pains. And then as like a blanket medication, like a fire hose to a fire in a way, the Medrol dose packer methylprednisolone is a 6-day course of steroid that you would take, where it's 6 pills, then 5, then 4, all the way down to 0. And that can really help kind of just immediately zap and calm down and hit the reset button for arthritic types of pains. It's not a medication we can use very commonly, but we can use it once in a while when the pain is just really bad. Now, there's other things we can try too conservatively, like bracing. And of course, here on the left side of the screen is something called shockwave therapy, which doesn't have the best evidence behind it, but some people do like that. And we can always talk about that later. But the bracing can make a difference. What it does, and you can look on the x-ray here, on the left side of the screen, you'll see the x-ray with the collapsed joint. we apply this brace, which is an unloader brace, and then you'll see the joint space here gets opened up because of the pressure from that brace kind of bending the knee and straightening your leg out. So it does show, you know, the bracing does help, but it's a bulky brace. Not everyone wants to wear that kind of a thing. So now let's talk about interventional management. And I'm trying to keep an eye on the time here. But as far as intervention goes, there's plenty of kinds of injections, lots of different kinds of procedures we can do to help kind of stop pain in its tracks and get rid of the arthritic kind of flare-up. A lot of you have heard of steroid injections, and those are fantastic for using once in a while to kind of put out the fire in a way. Steroid injection, there's many different kinds of steroids, and they all aim to kind of decrease the inflammation. We can only use them once every 3 to 4 months because they do kind of make the joint spaces and the cartilage a little weaker. So with that in mind, we can do this every 3 to 4 months. Now, if the pain comes back sooner than that, there's other medications we can try. Ketorolac or Tramadol, or I'm sorry, Ketorolac or Toradol down here in the bottom right. It's like a liquid Advil that we can inject directly into the joint. And studies have shown that between the steroid and the Toradol here in the bottom right, those two medications work exactly the same in terms of efficacy and longevity. So you'll get about 3 to 4 months of relief with either of these, and just as potent of relief with either as well. So if the pain does come back sooner, it's always nice to know that we can use something like this liquid Advil or Toradol to kind of calm the pain down in between. Now, these two things are great to use periodically, but if we're going to be using them as often as 3 to 4 months apart, then we may as well look into something else like gel shots or chicken shots, people might know them as. Gel, and the reason is because they used to be made from the comb of a rooster. Not anymore. Now we don't have to worry about allergies. They're made in a lab, and then they get shipped to us in these little vials, and we can inject them. Essentially what it is liquid cartilage that's grown in a lab. And some people get them as a series of 3 injections every week for 3 weeks, and some people do them as a single injection of all 3 at once. Studies show that it doesn't matter which one you get, if it's the single or the 3 injections, they both work the same and last just as long, which is about 6 months. Of course, pain may come and go or not last that long or last even longer than that. But you know, we're not really going to know unless we try it. And genetically, people are susceptible to different things. So people may do better with this gel than the steroid, and so that's why it's a great option to try. Now, if we look a little further, sometimes we come in with a lot of fluid in the knee. What do we do about that? Well, that fluid it's joint fluid, and but not just joint fluid, it's inflammatory joint fluid. So it's important to take that fluid out if we're injecting anything, because that water on the knee, so to speak, can be painful, and it can cause further kind of irritation and cartilage degradation over time. So sucking out the fluid is good. The problem is it comes back. So we usually tend to put an injection of some kind into it, like the gel to kind of, or the steroid to kind of calm down that inflamed cartilage and prevent this from filling back up again. Prolotherapy is a lesser common known injection that involves injecting sugar water. Now, I wrote other substances here on the screen because historically, and for about 150 years this is being used, people have tried different things, injecting glycerin, phenol, some weird things here. Cod liver oil, I think, was one of them back in the day. But in truth, all you need is a little bit of sugar, because that sugar water type injection helps to rough up the cartilage that you're injecting into, and it sucks up the inflammation into the sugar granules, and it helps kind of restart the healing process. It's a little more gentle than injecting these other substances I mentioned, but it can help. So sometimes, and there was a study back in January that came out last year showing that doing 6 of these every month for 6 months actually does help kind of calm down the pain and prolong relief. So it's always an option I explore with patients when we want to stay away from something like cortisone or Toradol because of other bodily issues like diabetes or things like that, and we want to try something a little more gentle. But some patients say the opposite and say, I want to try something more aggressive. And that's when we look into things like orthobiologics. And you might have heard of things like stem cells, PRP. There's a whole slew of different things, and we'll talk about the most common ones here. But essentially, PRP, which is here, is where we draw your blood and we spin it down in a centrifuge, which you can see here in letter B. And then we get out this vial of your blood that's kind of separated into its components of platelet-rich plasma. So we draw out that plasma layer, or the yellow layer here at the top, and then we can inject that layer into a damaged area. What is in that yellow layer that we're injecting? Well, it's platelets, growth factors, a lot of healing properties. But the big thing with platelet-rich plasma is that it forms a scab deep inside the joint where you're injecting. And just like on the skin, when we get a scab on the skin, that it helps heal the skin. So the same principle applies to the knee. You're injecting the knee with this platelet-rich plasma, and it helps heal the damaged tissue. Now, if we take that a step further, we can look into something called amniotic tissue. Amniotic tissue injections, or the technical term is dehydrated human amniotic membrane, is a whole like slurry of growth factors and proteins that we can take from a dried up, irradiated placenta. So we're killing all the cells in it, sure. So there's no platelets, there's no white blood cells, red blood cells, there's none of those cells. No stem cells are involved in this, but it is, as you can see, this huge panel here of different proteins and growth factors. There is like a soup of protein powder that we can then inject into an arthritic joint, and that protein powder can soak into the joint lining, the cartilage area, and calm the inflammation and start healing. Now, if we take that a step further, I mentioned stem cells before. There's only 2 ways in the US that are cleared, FDA cleared, to harvest stem cells for injections into joints. One is through bone marrow. And the process is laid out right here in front of you, where we go into the back, or like the little dimple in your lower back on the hip, and we can actually core out some of that bone marrow and suck it out, spin it down, and we get the stem cells out of that blood, where we can then inject that into the damaged tissue and use those stem cells to grow back, theoretically grow back damaged tissue. Whether or not it does grow back lost cartilage is still up for research. We're still looking into it, but it does have a lot of potential to heal the cartilage and the bone and the tissue that's left. And so it can give you long-term relief there, more so than steroid would and things like that. The problem with these kinds of things is that they are pretty costly, and there's not a ton of research for it. And we also have to drill into the bone, which can be a little invasive. Still invasive, but less so, is the idea of doing fat stem cells. Now, what we do here is a mini liposuction type procedure on the abdomen, the love handles. I've even gone into the buttock area and the thighs to get fat out of the body and then process that fat down. In the bottom right, you can see there's a whole chemistry kit they give us, and it's like a whole procedure to get these stem cells out of the fat. Now, when we look at the older population, stem cells in the bone marrow decline over time, but stem cells in the fat actually stay pretty solid. They stay pretty healthy, pretty good, and they keep replicating with the health of our youth continuously throughout our age as we get older. Whereas in bone marrow, the quality of that tissue declines. So when someone who's a little older comes in and says, I want to do this fat stem cell injection into my arthritic knee, for example, we can absolutely do that, but we would do it through the fat, not the bone marrow, because the quality of the stem cells is greater in fat than bone marrow as we get older. So, and lastly here with interventional management is this idea of doing alpha-2 macroglobulin. What is that? There's a whole thing up here that I don't expect you to follow along with, but bottom line is, inside the joint, it's like a small environment of arthritis. It gets very angry and the fluid gets very inflammatory. The problem is, well, actually, if you think about it, that fluid, you don't see that in the body. You don't see the, arthritis flowing through our blood vessels, coursing through our veins, because we shut that down. There's a protein within our blood called alpha-2 macroglobulin, which is A2M. But again, you don't have to remember that. The point is that protein, which is in the middle of the screen here, sequesters and blocks all those little arthritic components from flowing through our body and kind of delivering themselves everywhere and causing arthritic ramp up everywhere else. So that protein is fantastic, but it's huge. It's a big protein and it doesn't fit into the joint. So what some researchers discovered about 4 years ago is that you can actually draw someone's blood, take that protein out of the blood and inject it directly into the joint, and it sequesters the arthritic fluid and stops arthritis from getting worse in its tracks. And I got to say, we've done this quite a bit in the office. It is a mixed result. It's the stem cells do offer a little more relief than the A2M does, but for those that it does work on, it's night and day difference. People do really well with this kind of an injection. But again, research is still out for it. So coming up on time here, we'll quickly go through. I just wanted to round this whole thing off with the surgical options. We have 3 different kinds of surgical options here we'll quickly touch on. One of them is the partial knee replacement, which people might have heard of. Sometimes patients say, you know what, only one side of my knee is collapsing on itself. I'm going to do a partial replacement. It's less invasive, less metal in my body, it's easier. All of that is false. It's actually a lot harder to do a partial knee replacement than a full knee replacement because we have to be more delicate with what we're doing here. With a full knee replacement, we're just taking the whole knee out and changing the cartridge, changing the ink cartridge in a printer, so to speak. We're just taking it out and putting a new knee in. With a partial knee replacement, we leave all the ligaments intact and we have to slowly carve out half that knee there so we can put the metal in and then make sure it sits nicely when we put everything back over. And we leave everything else in place. So the idea of having all your own native tissue there is great, but it's a lot harder to do than just simply kind of replacing the whole knee joint, as you can see here. Replacing the whole knee joint, it looks like this. You're putting in metal and plastic and you're kind of getting rid of all the ligaments, but you're making sure that it stays taut by putting this plastic piece in between the 2 metal to kind of keep everything intact. So, and then arthritic pain, we can do arthroscopy as well, which is 2 little poke holes in the front of the knee and 1 possibly above the knee, and then look into the joint there and kind of repair anything that's damaged. The problem is, if you look on the bottom of the screen, you can see all that white kind of surrounding here, it's frayed away. And in the middle, this is what arthritis looks like. And up top, this huge thing is arthritic change. You've lost the cartilage at this point. And so doing something like arthroscopy, where you're going in with these small poke holes, isn't going to do anything for something that has no cartilage left. So for patients that say, can I get arthroscopy done instead of a knee replacement? It's not going to make a difference. So with that in mind, there's a lot of options here, ones that we didn't even know we had. But in truth, we personalize everything to the patient themselves and what their goals are, and also what other pre-existing conditions they have so that we can get people feeling better and tailor the treatment to the patient specifically. Knowing that for the most part, the best thing to do with arthritis, if we're coming full circle here, is get it stronger. Physical therapy and home exercises, that hard work and effort putting into getting the muscles stronger is truly the best way to kind of prevent arthritis from getting worse. However, if it has flared up, we have all these options in between to help it calm down. So,
hi everyone, this is Z from Yonkers Public Library. Thanks so much to Sally Pinto and Alexis and Barbara from Newark. Thank you to our community partners, WJCS, the City of Yonkers Office for the Aging, Westchester County Legislator Ruth Walter, Friends of Crestwood Library, and Yonkers Public Library for making this phenomenal partnership. And we thank each and every one of you for being part of our wellness community. Be well, stay well.